So it is my pleasure to present Dr. Ebru Oral, a prominent figure in the field of orthopedic surgery and biomaterials, and my roommate at the NIH study section, with a distinguished position as an associate professor of orthopedic surgery at Harvard Medical School. She also holds the role of associate director at the Harris Orthopedic Lab within the Massachusetts General Hospital, showcasing her leadership and expertise in the medical and research community. Dr. Oral's academic journey began with a Bachelor of Science, a degree from Boğaziçi University in Turkey, followed by a PhD from Purdue University. Both were in chemical engineering. So this educational background laid the foundation for her groundbreaking work in the development and application of polymeric materials for medical use. Her research primarily focuses on the science and application of implantable polymeric materials to solve medical problems, particularly in the domain of joint replacement. Dr. Oral has made significant contributions to the field with her work on vitamin E stabilized cross-linked ultra-high molecular weight polyethylene joint implants, making the first clinical application of such technology. So this innovation represents a major step forward in improving the durability and performance of joint implants, potentially extending their lifespan and reducing the risk of complications for patients. Beyond her contribution to joint implant technology, Dr. Oral's current research interests include the integration of therapeutics, which is going to talk about, into implantable materials. This involves the controlled local release of antibiotics, anti-inflammatories, and analgesics from these materials, offering a novel approach to postoperative care that could minimize the risk of infection and enhance patient recovery. Our work is aimed at providing translational guidelines for the use of these therapeutic implants, bridging the gap between innovative research and clinical application. Dr. Oral's expertise and innovation have been recognized with numerous honors, including her election as a fellow of the National Academy of Inventors, which is the highest national honor for inventors. This accolade reflects her significant contributions to the development of new technologies and solutions in the medical field. Additionally, she is a fellow of the American Institute of Medical and Biological Engineers, an honor bestowed upon the 1% to 2% of biomedical scientists, further affirming her standing as a leading researcher in her field. With over 70 peer-reviewed publications, an H-index of 38, numerous book chapters, preprints, and an inventor on 46 US and international patents, Dr. Oral's prolific output highlights her commitment to advancing medical science and improving patient care. Her work on implant manufacturing methods and materials continues to push the boundaries of what is possible in orthopedic surgery and biomaterials, making her a key figure in the development of next-generation therapeutic joint implants. It's an honor, Dr. Oral.
Thank you very much. I think that is probably the best introduction I've ever gotten. So thank you so much for that one. I hope that this audience, my talk will be especially apt for this audience as well. I see that your program is very much focused on, clinical application as well. So, well, with that, I'll start. I will actually give a little bit of an introduction on the current used antioxidant stabilized materials, although that's not really the focus of our recent research. Paxton, may I ask how much time I have?
You can take as long as you want, 1 hour.
Okay, perfect. I'll go at a reasonable pace. I don't want to kind of rush everything. So, All right, great. So, okay, let's see if these slides will move. It's not moving, but okay, here we go. Here are my disclosures. As Faxon mentioned, we have licensed some technologies for joint implant manufacture. So that's, I think, probably the most relevant disclosure here. So I do receive royalties from those. Let me start with an overview of our laboratory. As you can see, our core competency and our core work is really in joint replacements, but we do other work as well. We're basically a polymer material lab in the hospital. We have done and still continue to do a lot of work in hydrogel materials, also degradable materials, recently microparticles and nanoparticles as well, for different applications, including actually a load-bearing cartilage replacement that we worked on for many years, but we have some research in that area. We are also getting into bacteria detection and targeting because of our interest in infection, which I'll talk about today quite a bit. And then also preclinical surgical models recently, again, over the last 6-7 years for pain, infection, and bone loss, and some other aspects of orthopedics. We've developed some surgical models. And then also other surgical materials such as bone allografts we have been interested in and have worked on. So joint replacement, as many of you know, is a very successful surgery that's undergone by many, many people, over 1 million people in the US. The majority of these are hips and knees, which are the large joints, constitute a large volume, but the volume is also increasing in the smaller joints, especially the shoulder, elbow, and ankle. In fact, one of our newest materials I'll talk about, it has been implanted first in the ankle. So that's definitely an area of need. So our focus is on the ultra-high molecular weight polyethylene, which is one of the articulating surfaces of a majority of implants, especially in the US. In Europe, there are other bearing surfaces as well, especially the ceramic on ceramic bearing surfaces are pretty popular, but in the US, 99% of implants do have a polymeric bearing component. So ultra-high molecular weight polyethylene is a sort of a specialized polymer. It is a semi-crystalline polymer, so its crystalline regions, its amorphous regions, and the interplay of these are very important in its properties. Outside of the medical field, it is used in very demanding applications. So you see some of those over there, like in climbing rope or bulletproof vests, and even in the mooring of ships or, for kite surfing and things like this, where, you really need a strong material. So it's a very ductile and tough material. But the other interesting property that I'd like to tell you about, because it's really governs its manufacturing processes, is that it has almost no melt in the amorphous state above the melt. No flow in the melt state. So you can see there a solid brick of polyethylene that is above its melting temperature, which is about 137 degrees C. And you can see that it is a solid, albeit a transparent solid in this case. So we can actually process it in solid state. And this comes with its own advantages and disadvantages, which I'll talk a little bit about. So medical polyethylene manufacturing, basically the resin powder is converted into solid forms by heating and pressurizing. It's a little bit, its processes are different than some other polymers because of this lack of flow in the melt state. So the majority of these implants are formed by either slab compression molding, which is basically you see in the middle there, these large platens that are heated and pressurized, and the material comes out in really large rectangles that are cut into bars. And then a specialized process called ram extrusion, which is not really an extrusion process. It's again a sort of a heating and pressurization process that pushes the material with a ram as it molds, and it comes out in these circular shapes. Typically, then these would be machined into implants that you see up at the top there. But for much of the therapeutic materials that I'll be talking about, we are interested in direct compression molding. That's basically a small scale molding process of the same, but small, where the shapes you get are closer to your final sizes. That's of course to limit the temperature and the time that the therapeutic agents are exposed to the molding conditions. So the state-of-the-art polyethylenes today are highly cross-linked. So as I mentioned, polyethylene is formed from crystalline and amorphous regions, and I'll talk a little bit about the motivation behind the cross-linking, but typically these materials are irradiated by gamma or E-beam irradiation to high radiation doses around the 50 to 100 kilogray mark to cross-link their amorphous regions. And that's for increasing wear resistance, which has really been a very important advance in the manufacture of these materials. So state-of-the-art materials are highly cross-linked. They're also now antioxidant stabilized, mostly by vitamin E, although there is one other antioxidant called Covernox, which is a medical grade of Ergonox tantan, commonly used in stabilizing polymers, that is being used also as the antioxidant stabilized polyethylene. And this is, as Faxon mentioned, we've done a lot of work in this field. This is to improve the oxidation resistance of the material. I'll talk a little bit more in detail how. So basically, wear of polyethylene for many decades was the major problem in its performance. So how does wear occur on polyethylene surfaces? Here's a micrograph of a retrieved surface of a hip. And in the hip, you have more crossing motion, so you can see it a bit more clearly. But what happens is that the polymer is deformed and aligned in the primary direction of motion, which is the flexion extension direction in this case. That weakens the material in the transverse directions. And when you have crossing motion in the other directions, then you can have breakage of the material, which shows up in fibrils, like you see on the surface, and then eventually as wear particles. So the accumulation of these wear particles, which cause the bone to die around the implant, was really the main culprit for the revision of these implants for many years. So this is caused by large-scale deformation of the material, which incidentally also gives it, its ductility, its good, tough properties. But basically, radiation cross-linking is used to decrease this deformation ability so that this mechanism is lessened. And you can see it on the surfaces of these materials. On the left side is a low cross-link material. On the right side is a high cross-link material. You can see that the buckles on the surfaces are much less, and that indicates the the decrease in ductility. And in turn, the wear rate also decreases. You can see the dependence on the radiation dose on the right side there. As I mentioned, many of the clinically used materials are irradiated between 50 to about 120 kilogray, depending on the application. So that's the motivation behind the cross-linking. What happens during irradiation for cross-linking also is that the free radicals are formed everywhere in the material. The ones in the amorphous phase are mobile enough to actually combine and cross-link. So the material is only cross-linked in the amorphous regions. And then in the crystalline regions, the free radicals can actually live for a very long time because they can't jump from chain to chain. They can only migrate along the chains because of the rigidity of the crystals. And you can see on the right side there, the actual signal of the free radicals many years into the storage of the material after its irradiation. And this was a problem because these free radicals would migrate to the amorphous crystalline interface and react with oxygen, and then oxidation would occur in the material, and then chain scissioning, and eventually, you lose a lot of its good properties. So because of this, this was the motivation behind the antioxidant stabilization to prevent against oxidation in the presence of the free radicals. So in comes vitamin E. So there are several methods of incorporating vitamin E into polyethylene, but I only talk about one because that's the predominant one currently. So vitamin E is a lipid, and we mix it into the polyethylene resin powder and then consolidate into solid forms like you saw there. It's actually very resistant against heating, so protecting vitamin E during the molding process is not a problem. And then the material is radiation cross-linked further. So many of the materials that are out there today are using different amounts of vitamin E and different amounts of cross-linking, but this is sort of the process by which they're made. So vitamin E is very good and soluble in polyethylene. So it does not affect its properties, neither its crystallinity, nor its mechanical properties, nor its wear resistance by itself. So it's a great additive that way. But what it does is, because it's a free radical scavenger, it actually reduces the amount of cross-linking during the radiation cross-linking process, which is very important for wear resistance. So in the middle there, you see that relationship. As you go higher in vitamin E content, you actually come to a place where you can't cross-link the material anymore. It's pretty efficient in that free radical scavenging. So because of this, the materials that are out there use about 0.1 to 0.2% vitamin E and not more to be able to balance that wear resistance. We also came up with a few methods where we increase the immobilization of the vitamin E in the polymer. So, not all of the vitamin E will migrate out of the material eventually. So the vitamin E is grafted in the polyethylene. And then briefly, I'll talk about a few of these methods. Basically, in the blended materials that are irradiated, you still have free radicals in the crystalline regions that will migrate out into the amorphous. And the vitamin E will then be used to kind of prevent these free radicals from further reacting. So in order to prevent that and preserve more of the vitamin E for longer term use, we came up with some methods to decrease those free radicals without melting the material. So this is the important part about the free radical reduction processes. The free radicals can be reduced to undetectable levels by melting the materials, the crystals, because then the free radicals can escape and recombine. But that also decreases mechanical properties of cross-linked materials. So in order to avoid that, we wanted to come up with methods that reduce free radicals but not melt the material. And these are two of those. One is irradiation at a higher temperature, and then the other one we call SEMA, which is a mechanical cold irradiation mechanical annealing process, where we can actually give mobility to the crystals by mechanical deformation to reduce the amount of free radicals without melting the material. So these are both techniques that are currently used in clinical implants. So finally, this very newest material that actually went into knees last September and ankles at the turn of the year is a chemically cross-linked material that is processed by this method called high temperature melting. So we discovered that when we took polyethylene to very high temperatures, around 300 degrees C in inert atmosphere, we were actually able to improve its molding conditions. So typically polyethylene is molded for a short period of time, but because it has very long chains, that's actually not the equilibrium for the molding process. So by taking the temperature to a higher level, we were able to have more diffusion of the chains across the grain boundaries and have better molding, which increased its elongation. But at the same time, what happened is at these higher temperatures, we actually have controlled chain scissioning, which we can see by the formation of the vinyl groups at the end of the chains for this polymer. That's what you're seeing there. What this does is it actually increases the toughness. You can see in the work to failure on the right side as a function of how many vinyl groups you form. And then at some point, the scission is, too much, and then you start dropping the properties again too. So we use this window of opportunity to actually make tougher cross-linked materials. And so we combine this method with chemical cross-linking, which we're doing by using a peroxide. So instead of the irradiation process, we're using peroxide that decomposes at certain temperatures to cross-link the material. So what you're seeing here is that we can cross-link the material by using peroxides. Actually, they're a bit more efficient because since we're using the blend of the material and molding, so the cross-linking is happening at the same time as molding. So it means the material has more volume, more amorphous content to cross-link, and therefore it's a bit more efficient. Interestingly, we had started working on this method for different reasons, but currently there is a shortage of gamma sources for gamma irradiation, and therefore gamma irradiation is commonly used for sterilization, which is, I think, still continuing. However, gamma irradiation for high dose cross-linking, which is required for this material for clinical applications, is actually becoming harder. So this is at the same time provided an alternative manufacturing method, which is advantageous to avoid most of that high dose cross-linking as well. So these are the properties of chemically cross-linked and high temperature melted materials using two different peroxides in the first two lines of the table. And you can see that the impact strength for these materials have gone up quite a bit from the cross-linked materials that are currently being used clinically while maintaining most of the wear resistance. So with that, I'll come to the therapeutic applications. So the problem that we have been focusing on mainly is infection, and that's because it is now the top reason for revision for joint replacements. And not only that, I mean, the large amount, the large number of patients makes this a big problem, despite the incidence of infection overall being about 1 to 2%. But also because it's a very morbid condition. The condition itself is morbid, but its treatment can also be morbid too. If any of you know anyone who has gone through this, it's really something that affects people's lives quite a bit. And what has happened is, due to the radiation cross-linking methods becoming more prominent and osteolysis is a problem going away, in the last 20 years, the focus has really shifted to infection. You can see there a comparison of 20 years before and 20 years after for top reasons of the revision. Not only were the revisions more in number at 10 years, but also loosening was the top reason. And now infection is the top reason. So we are motivated to do something about this. Recurrence of infection also is a big problem, because with each recurrence, the probability of eradicating infection becomes less and less, and there are some morbid consequences such as arthrodesis and amputation in those cases. So how is PJI treated in order of increasing invasiveness? So obviously, if the implants are very well fixed in place, we don't want to remove them. So there's debridement and implant retention, basically just washing away and removing anything that is, apparently has bacteria. And then the second method is liner exchange, because the polyethylene piece of the implant is the easiest to remove. This can be done pretty easily, but you can see that these two methods are not very successful. Those are the success rates next to the lines. And then so the gold standard is called a two-stage revision, where the infected implants, everything, all the components of the implants are removed from the patient, and antibiotic eluting bone cement spacer is replaced to basically preserve the space of the joint, because now the patient doesn't have implants. There's a gap between the two bones. And then IV or oral antibiotics are used to eradicate the infections. And then this is meant to be done on average for about 6 to 8 weeks. However, the average from the literature is about 4 months. That means there are some patients that really take a very long time, or sometimes they don't come back for the second surgery because they can't or won't. So then after the infection is deemed cleared, a new set of implants are put into the patient. As you can see, this is a pretty, morbid treatment. It affects the patient's lives a lot. And not only that, but it's not perfect either. The success rate in the best case is about 85%. So I want to just say a few things about bone cement as a delivery device, because this is the one thing that is available to the surgeons to elute antibiotics into the joint space, and it's used as a as a supportive tool for sure. However, the one thing about bone cement is that it's not meant to be a load-bearing device, and therefore fracture is very common, especially in patients, as I mentioned, that can't come back for a second surgery. That means they have now a bone cement spacer as an implant, which is really not the ideal condition. So we asked joint surgeons, knee surgeons in this case, what they're actually doing during revisions. Are they all using bone cement? How are they using it? So what turned out is that actually 44% of them are using a primary joint implant. That is a metal femoral component and a polyethylene tibial component, and loosely cementing them in place. So if they need to, they can take it back out. But in case they leave it in there, that's going to be more successful from a load-bearing perspective for that patient. So, but there is no antibiotic-eluting polyethylene. So this is a virgin polyethylene that's used with, with cement in these cases. And this is actually off-label use. There's no implant that is approved for this purpose. So we thought that we can incorporate antibiotics into polyethylene and give them an additional tool that they're already implementing in this case. So, So we started working on polyethylene and incorporating therapeutics. So this is a paper that we published of sort of our proof of concept studies, where we looked at putting vancomycin in polyethylene and compared that to bone cement materials. What we saw was that due to the compression molding process and also the melt properties of polyethylene, we were able to get these eccentric domains of the drugs. So one of the reasons also that I told you about vitamin E before is that, as I mentioned, vitamin E is hydrophobic, has solubility in polyethylene, so it is not a phase-separated material. It does not affect much of the properties of the polymer. However, the hydrophilic drugs, these antibiotics, are definitely phase-separated in polyethylene, and you can see the domains there. And depending on the size and shape of these domains, they can affect the mechanical properties quite a bit. So you can see that the structure of the polyethylene with these eccentric domains is different than that of bone cement, which has flow, while molding around these particles. And what this gave us was that we could use a lower percentage of antibiotics to obtain similar wear rates to the bone cements that were being used. So this was a really good first step to start working with these materials. And in this paper, we showed that we could incorporate vancomycin and elute it to effect. So with this, we have sort of started working, as I mentioned, on what is a spacer. So that's a temporary device that would be similar to what bone cement is doing right now. So this is a gentamicin eluting spacer. And we were able to show that we can elute similar amounts or higher amounts compared to the bone cements that are out there. And then, of course, the wear rate, as expectedly, of a metal on polyethylene is much better than a bone cement on bone cement articulation. And then, of course, the compressive properties of polyethylene are much better than bone cement. So with that, we started also exploring what other types of antibiotics can we put and what is the amount of antibiotics that we need to put in polyethylene. So this is a recently accepted paper where we looked at the thermal stability of the antibiotics, some of the commonly used antibiotics, and then we investigated their elution profiles that you can see here. We usually do elution experiments on small samples, but then we extrapolate the numbers to an average knee implant, which is about 100 centimeters square in surface area. So this set of antibiotics we were able to incorporate at 7 and 10%, a maximum of 10% because of the mechanical properties, and I'll come to that a little bit later. So the other thing that we wanted to know, and this is not quite very well known. So a lot of the dosing guidelines for antibiotics are based on systemic administration and also on MIC numbers, the minimum inhibitory concentration of the drug versus a certain bacteria that is in suspension. So as you well know, infections that are associated with the medical devices comprise bacteria that are on surfaces which can behave very differently. So what we wanted to know was to actually have some best case and worst case scenarios in terms of how much drug we would need to elute from a device for how long to eradicate or inhibit different bacteria. So we typically use bacteria Staphylococcus and Staph epidermidis, which are the major causative bacteria in orthopedic infections. But typically we use a reference strain that's very susceptible to the drugs that we are working with. And then we use different strains, clinical strains that have different varying levels of intermediate resistance or resistance to some of these drugs to basically envelope a best case and a worst case scenario in terms of concentration. So we have now a subcutaneous implantation model that we've been using with plates where we inoculate the bacteria. We implant the plates and then we inoculate them with bacteria. And then we look at both the bacteria on the implants as well as the tissue over a period of time. And with that, we saw that even the susceptible bacteria does produce these communities that are more resistant, that acquire resistance. And then, of course, the inherently resistant bacteria actually have quite a high amount of resistance. So we have capped our number of gentamicin, a concentration of gentamicin at 500 microgram per milliliter. If we have to use more gentamicin than that, we deem that sort of the worst case scenario, and we don't go above that. So that's why you're seeing the sort of dashed lines in the concentration curves there. For susceptible strain, it seemed like we are getting to about 200 microgram per milliliter, which is much more than the MIC, but we will be using that as a sort of a guideline for releasing enough drugs, especially in a prophylactic case. So the other, challenge that we have in vitro studies is, how do we test for antibacterial effect that makes sense, that we can follow over a period of time? So while we were thinking about that, we came up with this method where we are actually putting the device and the bacteria in the same culture and we're monitoring them over time, except we don't do tissue culture. Well, we do tissue culture as well, but in this method, we are using a chemiluminescent assay to see in real time how much bacteria we have in the environment. And the other important thing is that we use the same bacteria population over this period of time. So we change the media, but we keep going with the same population, which is more clinically relevant. So we use this method on the right side there. You see the efficacy over a period of days. We use this method to ensure that we had activity for some of these materials that we're using against the susceptible strain, but we're also able to see that we are not effective against the resistant strain. So we can differentiate using this method in real time, which is a tool that is going to be useful. So we showed that the amount of sample that we're using in these tests is a small strip, which corresponds to about 2% of surface coverage for this average tibial implant that I was mentioning. So we saw that for these set of antibiotics that we incorporated, we could see activity over a period of about 3 days with even these small amounts. So we know that we have a pretty good leeway of how much surface we should cover with these drugs and what concentration we should use. So another sort of central idea that we've been using is to see if commonly used drugs in orthopedics can synergize with antibiotics. The reason why we're investigating this is, as you know, there is concern about resistance, but there are not a lot of new antibiotics, and synergy has been explored mostly for antibiotic combinations, but not with non-antibiotic drugs. So we actually observed, because we were working with pain medication as well, that some pain medications can actually act additively and synergistically with the antibiotics. And in this case, you're seeing the effect of bupivacaine elution, bupivacaine, which is a local anesthetic that's commonly used, bupivacaine elution from the polyethylene, its effect on the gentamicin, MBC for gentamicin in suspension. And it was, helping MBC. It was reducing it quite a bit, bupivacaine elution. So that's where we started from, and we've been exploring some of these combinations. So we incorporated actually combinations of bupivacaine, vancomycin, and gentamicin in polyethylene. And as I mentioned, we try to set some guidelines for ourselves. So we try to be above MBEC on day 1 of our experimentation, and then at least MIC and above MIC at day 7. So those are the general guidelines that we've been working with in terms of concentrations. And the MBEC, as you saw, was about 200 microgram per milliliter for the susceptible strain. So with that, we have quite a bit of leeway, again, with the concentration, and we can do this, pretty well in terms of concentration. So can we detect synergy with this method, the chemiluminescent method that I talked about? We can. So we went and tested, basically determined the lowest amount of antibiotic we had to have in a sample for it not to work. And so that was, in this case, you can see 1% vancomycin is not, there's an inhibition effect, but then the bacteria grow back, between day 2 and day 7. And then when we added bupivacaine to this material, we were able to see the effect. So we are working on this basically to test out some other synergies as well. So now we know, okay, which type of drugs can we put into polyethylene and what type of concentrations we have to deliver them in for efficacy, but what are going to be the actual concentrations in vivo? So this is, again, some information is needed in this area for local delivery devices, because much of the literature discusses elution profiles from the materials, but they don't actually go into predicting what's going to be the in vivo concentration. So we can build a few different sort of PK/PD models to do this. Unfortunately, there's not a lot of information in vivo for the clearance of these drugs with an intra-articular administration. So we have done, excuse me, we've gone 2 different ways. So for drugs where we don't know the clearance from the intra-articular component into the system, we just use a half-life model, and we use the half-life that is known either for that compound or something similar to try and estimate a concentration. And then for bupivacaine, which we actually, and gentamicin actually, for that we have some information with an intra-articular administration and clearance from that into the system, we have actually built a 2-compartment model where we try to simulate the more realistic scenario of the intra-articular administration, the prediction of the knee concentration, as well as the system concentration for concerns of toxicity. So our input, we model with the Pepys-Korsmeier equation. It fits many of our elution profiles quite well because these are not degradable materials. This is a pretty good model. So we model, the elution profiles for input into the model. And then here you can see for vancomycin, there's some information on the half-life in a porcine model, which is about 6 hours. So we use that to predict intra-articular concentrations that would be coming out of our implants and different surface areas and different concentrations. And then because this is not a very exact science, we tend to do worst case and best case scenarios with 3-hour and 12-hour periods of clearance, and that probably simulates different patients as well. So this is how we have been doing most of our predictions. And then, as I mentioned, for bupivacaine, where we have actually these actual rates published, then we can estimate also system concentrations. And we found out that in the case of bupivacaine, the local delivery device, as expected, did not reach toxic levels even at the very high concentrations, because that's one of the motivations of using local devices, that their their maximum concentration obtained will most likely be less than what you can do with a bolus injection, which is the standard, really. So we wanted to also go ahead and try and learn more about these clearance parameters for the drugs of interest. So we are developing a microdialysis method in the rat, where we implant microdialysis membranes in the muscle, bone, and skin around the injection site. And we have been validating this with the intra-articular injection of vancomycin to see if we can gather similar data that to the pig, if we're going to get similar clearance levels. And then we are hoping to use this method both with the local delivery devices and also just to determine the clearance parameters for drugs that may not have them for intra-articular administration. So in terms of in vivo efficacy testing, we have developed a number of methods, but this is one where we have really established consistently an infection. So we like this model. It's a joint replacement model, but it's not really a biomechanical joint replacement model. What we wanted to do was to actually capture the trauma that's associated with joint replacement, and also have the implant materials in there, because we're especially because we're interested in trying out different polyethylenes. So we have a transcondylar implantation of a polyethylene plug in the femur, and then we have a craniofacial screw in the tibia. And the way we do the infection is we first put about 1/5 of the concentration of the bacteria in the tibial canal before the screw is placed, and then we put the rest of it in the joint space before closure. So with this model, we have been able to establish and keep an infection for up to 6 weeks without sepsis or general side effects to the animals. And what we also wanted to do, the reason why we did this in the rat, is we wanted to use gait analysis and see if we can use this as a supportive outcome for understanding how bad an infection was. So you see that little video there. We do video recordings of the animals, and we can we have the side view as well as the ventral view, so we can calculate some of the gait parameters from these videos. So we saw that basically the thing that correlated very well with histology and then the gait with the gait parameters was the bone loss around the implant. And this continued to increase over the period of the study. So we are using bone loss in this model definitely as a secondary outcome because in this type of model, the bacterial count can sometimes be very misleading. It's not very clear what the state of the infection is, whether you've cleared some of it or not cleared some of it. And so bone loss has been a more dependable outcome. And then the gait parameters, as I mentioned, are correlated with the infection, but most likely, I think, with the bone loss, because we can see significant differences sort of towards the end of the study where the bone loss is quite substantial, and then the animals are feeling the effect. And these three parameters, duty factor imbalance, hind limb to port symmetry, and phase dispersion, are quite good in understanding or demonstrating the state of the infection functionally. So we use this model a lot. So, and then finally, I'll talk about sort of manufacturing alternatives for these types of materials. So as I mentioned, and I'm demonstrating here, that the mechanical properties of the materials are actually detrimentally affected with the increasing concentration of the drugs. Thankfully, for antibiotics, we don't have to use too much drugs. So you can imagine, using concentration less than, about 7 to 8%, which is, I think, as a maximum where you want to be. And the mechanical properties would be comparable to, clinically used materials. But, what else can we do to improve these properties? So one idea that we've been working for a long time, and it's a feasible one, is basically spatially controlling where we put the antibiotic-eluting polyethylene. In this case, you see the red portion that you see on the implant there is rifampin, which is red. And so rifampin containing polyethylene on the rim of the hip implant as well as the backside of the knee implant. So these are non-load bearing regions generally, and we can incorporate the material there. And when we do, the bulk of the material obviously doesn't change its properties. So we can maintain some level of mechanical properties that we want. And then in terms of, how thick can this layer be? Again, we have a lot of leeway here. This is a proof of concept study that we've done with vancomycin, and we were able to get about 6 weeks of elution with a minimum thickness of 350 micra on the implant. That's actually quite hard to get in a manufacturing setting, so it would most likely be on the order of a millimeter. But it's good to know that we can actually get quite a bit of desirable elution with this type of thickness. So recently, we just submitted this paper actually. We explored this method where we can control the particle size of the drug using a solvent-non-solvent method. And for gentamicin, we were able to show that we could make particles that are small enough that they're incorporated into the tortuosities of the resin powder. And what this does is basically it prevents the drug domains from being larger, and therefore helps the fusion of the resin powder during the molding process, affecting mechanical properties much less. And here I'm showing, as you can see, I'm not showing the comparison. Maybe you don't remember that. I apologize for that. But basically, a 7-8% loaded material has actually, up to about 20% higher mechanical properties, impact strength certainly, but also ultimate tensile strength. So this is a good method that I think we can use for uniformly molded antibiotic-eluting materials. And then this other method that we can use is basically if we have hydrophobic versions of the drugs that can be usable. In this case, I'm showing bupivacaine. Bupivacaine can be used both as a hydrochloride salt and also as a free base. So the free base version is soluble in polyethylene, so we can mix and match the hydrophilic drugs with the hydrophobic drugs in the amount that we would want. So we can do this two ways. One on the right is basically blending everything together, and then on the left you see a material that has been blended with the antibiotic, and then in solid form the hydrophobic version of the analgesic has been diffused into the solid form. So in each case, you can see that the morphology looks much smoother, and we don't see as many domains. And with that, the mechanical properties you can see down there are quite good, especially the toughness of the material is quite high. So I think I've come to the end of my So I wanted to basically summarize. We want to put all of these things that I've talked about together in terms of the types of the antibiotics, the spatial control, And then finally, I didn't talk today about how we can make these materials wear resistant. I talked a little bit about mechanical properties, but we can combine these kind of ideas, the different methods for cross-linking, as well as therapeutic agent incorporation, to make polyethylene implants that can be used under the different indications for infection, both prophylaxis and treatment. Obviously, we have gone, first by engineering a spacer, because a therapeutic eluting polyethylene is not out there, and it has to be first. It has to have some level of confidence that this can be used in patients before we can move on to other applications such as permanent implants. So with that, I will thank. There's a lot of people's work in this presentation, so I'll thank some of my former mentees and my current mentees that are working on different aspects of these materials. And I will acknowledge our funding sources, and thank you very much for your attention.
Thank you very much for that really wonderful presentation, very translational, very patient-oriented, really nice. So any questions? We have Jonathan.
People.
Jonathan? Oh, no question? Who was, yeah, so just unmute and...
Farsan, we have from Mashid a question.
Mashid.
Yes. Mm-hmm.
Mashid, can you unmute?
Hey, yes, thank you so much. Great presentation. I'm just wondering, do you think that it might have possible application in osteomyelitis, maybe this method?
So, osteomyelitis, spontaneous osteomyelitis, or we're mostly working with medical device associated things. So I talked about polyethylene. So wherever polyethylene is used, this method can be used, but that's mainly the joints. But we do have a few other things that we're doing, as I mentioned, for example, with nanoparticles, and it's very hard to actually use these hydrophilic drugs with nanoparticles. So it's a challenge, but we've been sort of going through it, and that's with the idea that we can be a little bit more non-invasive and do things, for example, in the spine, where you don't get a lot of chances of going in and doing open surgery and things like that. And then also polyethylene, I mean, it's used in joint implants. It's not used very commonly in the spine due to its own issues, but there are some alternative, I think, materials like sutures or other things that are made out of polyethylene. They're not very common, but they are in development or are being used in small volumes. So anywhere where you have polyethylene, this the methodology could be used for sure.
Nice. Ebru, how in vitamin E, which is really wonderful, really excellent work that you did in terms of vitamin E blended humor. Now, how do you optimize the concentration of vitamin E in terms of getting the best balance between oxidative stability and mechanical properties? Do you just titrate or?
So, well, we did a lot of work, and you can do so. The first type of material that we actually used or developed, which was it was a different challenge, but we had actually used diffusion of vitamin E into already cross-linked material. So there you don't really have a limitation of vitamin E preventing cross-linking because you've already cross-linked the material. It's a lengthy process, but that material had a maximum of about 0.7 weight % vitamin E, which is, I mean, which is a lot more than you need. Probably that material is not going to oxidize for the lifetime of the patient. So, so again, as I say, even trace amounts can protect for a long time. You know, no one knows for how long. So the in vivo sort of oxidation prediction is not. It was mostly, these methods were mostly based on materials that didn't have antioxidants. So we actually also learned along the way that for materials that are in the body, you can have different initiation mechanisms of oxidation. For example, the lipids that are absorbed into the material can initiate oxidation. And so we developed some tests to do that. But in many of these tests, like even the smallest amount of vitamin E, which is actually provided by the manufacturer at 0.1% vitamin E, so a lot of people are using that. Even that is extremely hard to oxidize under normal conditions. If you have adverse conditions, if you put a lot of lipid, if you do thermal aging, you know, all of these things, you can obviously oxidize and rank the materials. But frankly, clinical relevance-wise, I think they will be fine for a very, very long time. So in that sense, I don't know if there is an optimal material right now, because also the clinical information on vitamin E containing materials shows that they're not really oxidizing of this moment. I mean, the earliest one has gone into patients, I think now almost 16 years ago. So, you know, if and when they oxidize, then we will probably have a link of the in vitro methods to in vivo. But in terms of oxidation, we don't really, you know, we have, I think, pretty sufficient vitamin E, even with the lower amounts. So then it becomes you know, the goal becomes just seeing what kind of mechanical properties you want and going with that in terms of the cross-linking ratio.
Right. So I missed something. I like the whole idea of incorporating therapeutics into MWAP. Really brilliant, wonderful idea. And I was just wondering about what sort of mechanisms you use for incorporating. Is it just physical blending or surface modification?
So it is physical blending, but we also notice that, so it's a little bit difficult to ascertain this directly because, you know, all the analysis methods that you have to do for chemical composition on polyethylene have to be done in the solid state. So it's challenging to, you know, look at which bonds are there. So we use FTIR a lot of the times to look at sort of general composition, or we do TGA, this kind of thing. So we can't know for sure, even for vitamin E, which I said is grafted, but we don't actually have direct evidence of its grafting. We just can tell that less vitamin E is coming out of the material, so we know something has changed. But we saw for vancomycin and radiation grafting that even after all the vancomycin was gone from the material, it still prevented adhesion of bacteria on the surface. And when we looked at it with antibody staining, we saw that there was vancomycin still on the surface of the material. So we, you know, from that, we're deducing that, you know, irradiation can possibly also graft some vancomycin onto the polymer. So we are currently looking into how much you can do that with and that kind of thing, but mostly it's physical incorporation.
Okay.
I also have a question, so it's more translational, more at the end for the patients. So I know that the two-stage revision usually applies for the patients who had infection, but late infection, not early infections, not immediately after surgery. So you target which kind of infection, the early type that goes with the implant when you implant the first time, or late infections where you have two stages, exactly which one?
So two-stage is used for all kinds of infection, although different surgeons have different sort of thought processes on when they want to remove the implants, and sometimes they don't want to remove the implants. But late infections are so late infections, again, it depends also on the definition of what you consider a late infection. But I'm assuming you are talking about infections that that did not originate in the surgery, that came from some hematogenous pathway. So for those, obviously, it would be wonderful if one liner exchange could solve the problem. We are certainly technically able to make materials that we can try that with, but I think that would be the last application of this material in terms of how difficult it is to do a regulatory pathway. Yeah, we're going sort of one step at a time. You know, each indication has its own risks and benefits. So, but you know, technically, there's no reason why the material would not be able to be used under those scenarios as well. In fact, it's probably better because many of the times those late infections, the implants are fixed in place, so nobody wants to remove the implants. So if we're able to, you know, deliver something that's biofilm fighting, something like rifampin as well. That's actually why we started with vancomycin rifampin combination when we first started, and you know, tried to show efficacy in a biofilm model, because you know, if you have something really strong fighting that biofilm, then maybe a liner exchange in a late infection would be successful, and that would be wonderful. That would really change the lives of those patients.
Thank you.
Actually, yeah, a wonderful presentation and very amazing results. Really appreciated it. But yeah, actually, a follow up on Laura's question. I guess you answered it, but I was just wondering if you ever did any animal models with like already established infections and then put your implant in there and
Yes.
seeing if it, yeah.
Yes, we just published, actually, I didn't talk about it here, but this same infection model, we went up to, so the first time we did it to establish it, we went up to 28 days. And so the second time we wanted to actually do a 2-stage revision like, you know, model. So we went in, we established the infection, and then we went in at 18 days and changed the implants, just the polyethylene. So that was sort of like a worst case scenario in terms of, you know, just doing a liner exchange basically. And we put in a gentamicin eluting polyethylene. And that stopped the bone loss in that model. So we followed it for another month, so up to 6 weeks basically. So the you know, the control animals basically had more and more bone loss, and then the gentamicin eluting polyethylene basically stopped the bone loss. The bone did not regrow in that model. I don't know if it is even capable of doing that, because I don't know of many infection models where you know, you can regrow bone. But yeah, so it was a promising result. But yes, the reason why we established this model in the first place was to try and do a two-stage revision of the animal.
The other question I had is, what is the shelf life of these inserts and implants? So if you have antibiotics,
that's a good question. I don't know. We're looking into it. So the problem, so typically for therapeutic agents, if they're inside the polymer, they're actually kind of protected against the outside, you know, things that might be happening. But these guys, especially gentamicin, is very, very hygroscopic. So it you know, it takes in whatever water is in the environment and can go through different types of reactions. So we're looking into it. I don't know yet what the shelf life will be. We'll probably have to you know, store them under some you know, in our atmosphere, and definitely something that that is you know, low in moisture.
Okay, thank you.
Yeah, no problem.
So, Ebru, I like the dual delivery of the therapeutic agents. Could you do a triple delivery where you also include a growth factor I'm thinking about promoting tissue integration and healing while you are stopping pain and
Yes, I mean, I think technically, probably. I don't know if the thermal stability would be a problem. It might be, so that would need to be kind of determined. But yes, surely. Obviously, it would become more and more difficult, even with the dual delivery. I think it's more right now of it's a wonderful material that can solve a few problems, but I think the regulatory pathway is very arduous. I don't even know, frankly, how to go about the dual delivery right now. So I don't know about the triple delivery from that perspective, but
yeah. So my last question was when you are talking about the particle size control for improved molding.
Mm-hmm.
So how do you, are there any problems in terms of agglomeration? Because you have the finer particles, at least I remember from my chemistry, they would tend to stick together. Do you?
So we use a solvent, so we use a combination of solvents to actually put it into the polyethylene.
Okay.
And then, so then, when we're molding, we don't have this problem. But the drug properties affecting the molding process, I think there's a lot more, there's a lot to be learned there, because I still don't know, frankly, what is the major factor in in determining which drug. They all look a little bit different in their domains that they form in polyethylene, and I don't know exactly what factors governing that. We've looked at a lot of different things like surface polarity and size and hydrophilicity and all these things, and nothing seems to be really explaining it. So
Okay.
that's from my answer for the agglomeration, for just blending different particle sizes into polyethylene dry. But for the small particles, we actually use a solvent system. So
Okay. Yeah. Wonderful. That's really great. And really, thank you very much for this wonderful.
it was a pleasure, and thank you for your questions.
Yeah. Thank you. And thank you, everyone, for attending the seminar. This is, we have one more seminar left for next week, and you are free. So thank you, everyone. Thank you,
Bye,
everyone.
everyone. Thank you.
Bye.
Bye.